Thank you so much for the introduction, and thank you all for joining and attending in person. Now I know about the mics. I will try not to slurp when I drink my coffee. So you know, as you can see from the title, I think Sharon and I are a bit ambitious. We're going to talk about 3 geriatric conditions or syndromes: frailty, falls, and polypharmacy. You know, we don't have a lot of time, so this really is meant to be more of an overview of these common conditions in older adults. But I think, you know, by the end of the presentation, I hope that we can illustrate that these syndromes are connected and that management approaches, there are overlaps in terms of management approaches. We'll also talk a little bit about some of the observations that we have made in terms of frailty, falls, and polypharmacy in the aging World Trade Center general responders population. And a number of folks here at Sinai, including Hannah here in the conference room, have worked on these projects. And then lastly, we'll talk about some of the strategies that could be used to reduce falls and polypharmacy in at-risk older adults. So we'll start with the aging demographics, right? So we all know that the population in the United States is aging. So back in 2020, about 17% of the population was age 65 or more. The number is expected to increase to 22% by 2050. So as the population ages, geriatric syndromes, right, including frailty, falls, and polypharmacy, become more common. And then, you know, consequent to that, I think we are expected to see more adverse clinical outcomes, including mortality secondary to these geriatric syndromes. The point we really want to make here is that frailty, falls, and polypharmacy are connected. And we will try to explore some of those associations in our presentation today. We're also going to talk about a population that I think all of you are more familiar than we are, right? The general responders. So after 9/11, the Twin Towers collapsed, right, which created a large dust cloud that lingered in lower Manhattan for days and weeks. You know, rescue and recovery workers, cleanup workers, termed general responders or responders, work at ground zero for, you know, days, months, or years. They were exposed to the toxicants that were in the settled dust, right? And some of those are listed here on the right. And you know, because of these exposure, many of them have developed medical conditions that are World Trade Center related, and they are, you know, they're seeking active treatment in the World Trade Center Health Program, as you all know. So in response to this, the NIASH administered the World Trade Center Health Program, which provides free medical monitoring, treatment, mental health services, and benefits counseling to the responders. There are 5 clinical centers of excellence, CCEs, in the New York City area and New Jersey, and Mount Sinai being the largest of the 5. And these CCEs provide epidemiological surveillance, including, you know, the collection and analyses of health data that are collected during these annual visits by the responders. Treatments are also offered through the CCEs for World Trade Center related conditions, many of which are listed here. I don't know if you can see this, and include airway diseases, right, lung diseases, some types of cancers, and mental health conditions. But what we really want to illustrate is that this is an aging population, right? So this is the age distribution of the general responder population. You can see that age group 55 to 64 is the largest group currently. And by 2030, the majority of the responders will be 65 years and over, and they will be at risk for age-related conditions. So for that reason, there really is a critical need to better assess geriatric conditions, including frailty, falls, and polypharmacy, in order to deliver appropriate care for this population. And we'll touch upon some of the data reflecting these syndromes and conditions in our presentation today. So we're going to start with our overview of geriatric syndromes. So we'll start with frailty. So if I ask a room of clinicians to describe frailty, you'll probably come up with a list of characteristics similar to the ones listed here on the right. And that would include older age, weight loss, fatigue, weakness, falls, disability and dependence for care, multi-system physiological decline, medical complications such as iatrogenic complications during a hospital stay, delay or incomplete recovery from surgery, mortality. All this is to say that frailty underscores the concept of vulnerability, which is the body's decreased ability to handle stress in the setting of an acute stressor. So one of the earliest attempts to really define frailty took place about 20 years ago at the American Geriatric Society and Sinai Research Conference on Frailty. This panel of experts came to define frailty as a distinct clinical syndrome of multi-system physiological decline with increased vulnerability to stressors and adverse clinical outcomes. And these are thought to be some of the key features of frailty, including sarcopenia, which is the decrease in muscle mass and strength, as well as decreased physical activity and exercise tolerance. A lot of work, including epidemiological studies, have been done over the past 25 years or so on frailty. So we have a lot of data and evidence. We know that frailty, for example, occurs in about 7% of the population, in those who are over the age of 65. And the 4-year incidence of frailty is about 7%. The data here is taken from the cardiovascular health study, which is a large national study in the United States. We also know that frailty is associated with older age. In fact, in those who are over the age of 85, frailty occurs in about 25%, if not more, of that population. Frailty is associated with the female sex. It's more common in African Americans, in those with lower education attainment and lower income. Frailty predicts poor clinical outcomes, a few of which are listed here. Those who are frail are more likely to fall. So the odds ratio is 1.29, or about 30% more likely to fall, based on the cardiovascular health study. They're more likely to have worsened mobility, or worsened activities of daily living, disability. They're more likely to be hospitalized, and they have higher mortality. Studies like this have been done in many cohorts internationally over the past 20-some years, and these data, have been, found, repeated, over and over again. So there's not a single gold standard definition for frailty, but there are several that have been operationalized and well validated, and I'm going to talk about 2 of them. The first is the physical frailty phenotype, also known as the Freed definition. So for this specific definition, frailty is thought to be a distinct phenotype with 5 clinical characteristics listed here. These include unintentional weight loss, weakness as measured by decreased grip strength using a hand dynamometer, physical exhaustion, slow walking speed, that could be measured by a walking test, and low physical activity. If a patient has 1 or 2 of these 5 characteristics, one is thought to be pre-frail, which is an at-risk state for frailty. If 3 or more are present, then the patient is deemed to be frail. The Freed phenotype has another name. It's also called the Hopkins Frailty Assessment Calculus. So if you're interested, the web link is here for your reference. There's a different definition of frailty. It's called the Frailty Index. This is based on Rothwood's deficit accumulation model, which conceptualizes frailty as an at-risk state that's caused by age-associated accumulation of deficits. So one could calculate the risk by tabulating what's called the Frailty Index, or the FI, by computing the proportion of deficits across multiple physiological systems and domains of health and well-being. And some of those are listed here. So I think conceptually, this is quite different from the phenotype, right? So for the frailty index, it is accumulation of, let's say, chronic medical conditions, functional and cognitive decline, poor nutrition, disability, among others, that contribute to the overall risk for being frail. So these are some of the domains that are commonly assessed by a frailty index. I circle strength and mobility because these are key features, right, from the phenotype frailty. But in addition to that, cognition frequently is a component of a frailty index, as well as measures of functions, polypharmacy, and others. So our study team and others at Mount Sinai, including those from GRDC, have used this definition of frailty and developed and validated a 30-item clinical frailty index that's specific to the general responder population. We use monitoring data collected from these routine monitoring visits, from 2012 to 2017. These are some of the deficits that we have included in this 30-item index. And what we found was that frailty, as determined by the World Trade Center Clinical Frailty Index, was positively associated with age. So it increases with age. And on top of it, frailty, as determined by a high frailty index score, is more likely to have higher mortality than those who have a lower frailty index score, as shown in this Kaplan-Meier curve. There are also risk factors that are associated with frailty using the frailty index. We found that frailty was associated with increasing age. It's more common in women. It's more common in those responders who were in construction occupations at the time of 9/11, those with education less than high school, and those with high or very high 9/11 exposure, so exposure to the toxicants in the settled dust. There's some protective factors, right? So those who were in protective services, such as law enforcement, EMS, were less likely to be frail. And those who were never smokers or former smokers were also less likely to be frail. So I'm going to pivot to talking about falls. And as I mentioned, this is really a quick overview of geriatric syndromes. I know we're not doing justice. Each talk by itself could be a 2-hour discussion. So I'm going to pivot to talking about falls. There's an actual medical definition for falls. So a fall is defined as an unexpected event in which a participant comes to rest on the ground floor or lower level, not as a result of a major intrinsic event, such as a stroke or environmental cause, such as car stroke, right? And without the loss of consciousness. Falls are common. So in community dwelling older adults, falls occurs in about a third of those over the age of 65. Of those who fall, about a third of them would suffer a fall-related injury, right? And these numbers are higher in those who are over the age of 85. Falls are also common in other clinical settings, including in the nursing home, in the acute hospital, and in 40% of those who are recently discharged from the hospital. Falls have many adverse consequences. So 16% of ER visits and 7% of hospitalizations in the United States are due to falls-related injuries. 90% of hip fractures are caused by falls. Falls is the third leading diagnosis for hospital readmission. And it's a major reason for nursing home placement. In an older adult who falls and is unable to get up after the fall, called long lie, that can lead to dehydration, rhabdomyolysis, pressure ulcers, kidney failures, among others. So falls can really increase the healthcare costs. So back in 2015, it was estimated that non-fatal fall-related injuries cost about $50 billion to manage. Falls for an older adult could lead to a restriction of physical activity, right? Decreasing physical fitness, functional decline, which then can trigger a fear of falling, which in turn can precipitate social withdrawal, depression, loss of independence, and the cycle goes on. So falls can really trigger a downward spiral in a vulnerable older adult. There are many risk factors for falls. It's clearly multifactorial, and many of those are listed here. So intrinsic risk factors for falls include older age that we already talked about, cardiovascular abnormalities, including arrhythmia, cognitive impairment, including dementia, delirium, functional limitations, gait and balance problems. And this is probably by far one of the biggest risk factors that can contribute to falling. And this is one of the major major foci of falls risk assessment, which I will talk about in a little bit. Vision problems, orthostasis, and frailty. And there are many extrinsic factors that can lead to falls. So wearing the wrong footwear, wrong type of shoes can precipitate falls. Hazards at home, such as loose rugs, can trip a person over and cause falls. Wearing bifocals, and I can relate to this. There's certain angles that just don't see very well, and that's a risk factor for falls. And the use of fall risk increasing drugs, FRIDs, is also quite common. These are some of the classes of medications that can trigger falls. So, for example, benzodiazepines increases the risk for falls by about 57%. Polypharmacy, or the concurrent use of 5 or more medications, can also increase the risk for falls. And Sharon will talk more about this in her portion of the presentation. So as I mentioned in the beginning, one of the objectives of our study is to develop and test ways to better assess geriatric conditions such as frailty, physical and functional decline, and falls in the World Trade Center Health Program. So what we had done was we completed a pilot study involving about 106 general responders over the age of 50. We administered these geriatric assessments. For the fall assessments, we screen for their risk for falls by asking them 3 questions that are listed here. So we ask them if they have fallen and hurt themselves in the past year, if they've fallen 2 or more times in the past year, and whether they're afraid that they might fall because of balance or walking problems. So that you're aware, these are pretty standard geriatric fall screening type of questions, and Mount Sinai has adopted, I think, the first 2 in EPIC for those over the age of 65. So in looking at our pilot cohort of 106, I should comment that Hannah was a big, it was such an important part, investigated in this pilot, and she took the lead in drafting this report. So we found that in those who were frail, the risk for falling was quite high by the screeners, 34%. Oh, and I forgot to say that you screen positive for screening if you respond affirmatively to 1 of 3 questions. So that's compared to those who are non-frail, and that came in at 15%. We also assess fear of falling by administrating the falls efficacy scale, and we found that in those who are frail, high concerns for falls occur in about 29% of them, as opposed to 0% in those who are not frail. So really, all this is to say is that frailty and falls really are quite common in the World Trade Center general responders, and that the study population we looked at are actually younger than your typical geriatric population. So they're at a higher risk despite being younger. Right? So more reasons to really sort this out and figure out how to better assess for these geriatric risks, and so that we can bring the appropriate interventions. So with that, I'm going to pass this off to Sharon to talk about polypharmacy.
Thanks, Fred.
Yeah.
So when we talk about polypharmacy, there's really no defining definition of it. We generally think about polypharmacy as 5 to 9, 5 or more medications, but it's really any amount of medications that a patient doesn't need, So we want to when we talk about polypharmacy and ultimately deprescribing, we want to be looking at our medication lists and really asking ourselves, is there a reason why this patient is on it? So there are multiple definitions of polypharmacy. The consequences of polypharmacy are fairly obvious. You all know that due to increased metabolic changes in older adults, decreased clearance, they're at increased risk of adverse drug reactions, side effects. There is an increased risk of prescribing cascades, which I'll talk about in a little bit. Obviously, the more drugs your patient's on, the more risk of drug interactions, drug-food interactions, and then adherence. We know that with polypharmacy, there is an increased risk of decreased functional status, cognitive ability, especially if they're on CNS medications such as benzodiazepines and the non-benzodiazepines like Ambien. And there's lots of data that shows that polypharmacy leads to increased hospital admissions and costs, and ultimately can have significant consequences such as death. But it is also important to think about that sometimes polypharmacy is appropriate. And you can think of the example of heart failure. You know, your patient may be on a beta blocker, furosemide, an SGLT2 inhibitor, beta blocker, ACE inhibitor, and so forth. So in some instances, polypharmacy is appropriate. So we don't want to just whole cloth say, oh, you're on more than 5 drugs, let's start taking them off. So now, I've shown this in a previous grand rounds from last year, but I think it's important to remind ourselves that one of the consequences of polypharmacy is a prescribing cascade. And what a prescribing cascade is when you prescribe one medication and the adverse side effect of that drug is misinterpreted as another medical condition. And so then that medical condition is then treated with another drug, and so forth. You get this cascade. So an example I'll use here is, let's say you have a patient on amlodipine, they develop edema, you give them a diuretic, then they become hypokalemic, and then you have to give them potassium. And so then you've added three medications to a patient where if you start evaluating from the beginning and think about, is this medication appropriate for this patient, this condition, and the evidence. And so this is something to think about and as a consequence of polypharmacy. This is, we want to pivot here to show you some data from our general responder cohort, and this is self-reported data from their maintenance visits. And what they found here was, you'll see that at least half of the patients in this cohort, so there were 7,000 patients in this cohort, were on 5 or more medications. And at least 20% were on more than 10. And then about 8% were on FRIDs, fall risk increasing drugs. And so those drugs were benzodiazepines, first generation antihistamines like Benadryl, skeletal muscle relaxants, long-acting hypoglycemics, TCAs. And so you can see that polypharmacy is a problem even in these younger patients. And what they also found was that as their deficits increased, as their frailty deficits increased, their risk of polypharmacy was, the odds of polypharmacy was increased by at least 15%. So there is a correlation. The more frail your patient is, the more risk of polypharmacy you will have. With regards to FRIDs, same thing. When you look at these patients in this cohort, the more frailty deficits they had, the increased odds of them being on a FRIDs drug. So this is something important to consider when we are taking care of these patients.
we're switching back and forth. We'll do it one more time. So we're first going to talk about prevention and intervention for falls in frail older adults. I don't know if you heard of the 5 M's framework. So this is, I think, has really come to prominence in the past 7 or 8 years. This is a geriatric framework of care that many clinicians use when thinking about, providing a comprehensive, medically, psychosocially appropriate intervention for vulnerable older adults. So the 5 M's are listed here. Multi-complexity refers to the assessment, management of chronic conditions, including frailty. MI refers to cognition, such as cognitive impairment, dementia, delirium, and mental health. Mobility increase includes functional assessments, falls. Medications includes polypharmacy, looking at medication side effects, and then what matters most to align a patient's value and care goals to deliver care. So because the geriatric syndromes that we're talking about, frailty, falls, and polypharmacy are interconnected, the 5 M's framework approach could really be applied and concurrently address these syndromes. So this is what the 5 M's approach could look like in the context of falls assessment and prevention. So, for mobility, a clinician ought to obtain a good history for falls, because the past occurrence of falls is a strong predictor of future falls. A gait, balance, and mobility assessment absolutely has to be done, because these, again, are really good predictors of future falls. Footwear, which we'll talk about in a little bit. Sharon will talk about Fred's in more detail. And for multi-complexity, we look for visual impairment, right? Visual acuity issues, neurological issues, cardiac issues some of which we talked about, and postural hypotension and different factors that can contribute to frailty. You can see a lot of these map out very well to the multifactorial risk factors of falls. So because the risk factors are multifactorial, right, because of the 5 M's, doing a detailed head-to-toe history and physical examination is key to really identify and stratify risk factors for falls. So essentially I took the table from earlier, the intrinsic and extrinsic risk factors, and then populated them here just to illustrate, how you approach from head to toe to address each of the risk factors. Besides doing a detailed history and physical, functional assessments are key. And there's several types, right? There's functional assessment for strength, for gait, for balance. So this 30-second chair stand is a very commonly used assessment. This involves, having a patient sitting, in the middle of a chair with feet flat on the ground, crossing their hands on the opposite shoulders, tucking their arms against the chest, and they rise into a full standing position from the seat. And then they sit back down. So you ask them to repeat this over 30 seconds. And you count the number of repetitions. So these are the age stratified cutoffs. So for example, in let's say an older woman aged 80 to 84 who is only able to who performs less than 9 repetitions, that person is at an increased risk for falls. And the reason why these functional assessments are done really is because they mimic what goes on in daily activity of living. Right? So getting up from a seated position is what we all do. So they're designed and intended for that purpose. So this is an example of functional balance assessment. This one specifically is the 4-stage balance test. So there are 4 different stances. There's a parallel stance, semi-tandem, tandem, or standing on one foot. So you ask the patient to maintain each stance, and if one is unable to maintain the stance for greater than 10 seconds, then they are at increased risk for falls. Incidentally, last week, our study team was at a falls prevention intervention workshop, a 2-day workshop in a program called HOSA. And in that specific program, it uses the one-leg stand as opposed to the four-stage balance test. The time up and go test. So this is a very common test in the geriatric clinic, so you've probably seen or done it yourself. It involves having a patient standing up from a seated position, walking away from the chair for 8 feet, turn around, walk back towards the chair, turn around, and sit back down. Okay, so you time the patient to see how long it takes for one to complete the task. Now, this is probably one of the best predictors for falls. For someone who takes 12 seconds or more to complete the task, it is strongly predictive of future falls. The sensitivity is 88%, specificity is 94% for falls. It has good inter-rater reliability. And these are the normal ranges by age group. So you do a head-to-toe history and physical. You do a functional assessment, and then you make recommendations. So the U.S. Preventive Services Task Force has made these recommendations in 2018 for falls prevention for community dwelling older adults. Exercise intervention for falls prevention is a B-level recommendation, meaning that there's moderate evidence for moderate reduction of falls. For multifactorial intervention, it was a C-level recommendation. For vitamin D, US PSTF recommended against giving vitamin D supplementation, which previously was a recommendation for those who do not have a known history of osteoporosis or vitamin D deficiency. So these recommendations were made in 2018. More studies continue to be completed in terms of the efficacy of exercise interventions. So this paper was a Cochrane review, systematic review meta-analysis published in 2019 that looked at the benefit of exercise intervention in falls reduction. And exercise in general was effective in reducing falls in about 23%, by about 23%. Balance and functional exercise reduces falls by 24%. And these have high level, certainty of evidence with many, many studies. So what I mean by functional exercises, these are exercises that mimic daily living activity. So, pulling or pushing against the wall, right, for example, or squatting and standing up, because again, they mimic what we do normally. There's also some evidence that Tai Chi could be helpful, although it's low certainty because only 7 studies were included at the time. And the data on walking and fall prevention is unclear. I mentioned footwear earlier, and there's really solid data on this. So we know that sneakers, athletic footwear, is probably the best in terms of preventing falls. Right? So as we all know, these shoes have a low heel height, and frequently wide toe box, and they have slip-resistant soles. I just want to highlight that going barefoot, shoeless, has an 11 times higher risk for falls than wearing sneakers. So something to keep in mind. Just a few words about multifactorial assessments. So, you do the comprehensive assessment, history, physical, you identify risk factors. In a multifactorial assessment intervention, once these risk factors are identified, then the appropriate targeting interventions are then delivered or referrals are made, right? So for someone that you identify strength, balance, or gait problems, you can refer them to either exercise programs, physical therapy, or something similar to that. For someone whose home has trip hazards, right? So you do a environmental safety checklist and you remove those hazards for falls. You do a medication review and you tailor possible medications that can increase fall risks. If postural hypotension is present, right, we provide orthostatic education to help minimize the adverse effect of postural hypotension. So this goes on and on and on. So what I really want to share with you, and please circulate is this booklet. So I mentioned that we were at the hosted training. So that stands for Healthy Steps for Older Adults training last week. This is a multifactorial assessment intervention developed by the Pennsylvania Department of Aging. It's a validated intervention and has found to be able to reduce fall risks and hospitalization from falls. It's delivered by what's called a certified workshop leader. So we spent 2 days training to be a workshop leader. And and the booklet here is intended for the participant. You can see that it addresses different components of falls balance and it provides really useful recommendations in terms of how to compensate and improve on some of those deficits. I'm not going to go into this in great detail. It is quite busy, but the point I want to highlight is that because falls are so common and so detrimental in many people, the CDC has put a lot of stock in it. Right? So a lot of work has been done, and a lot of resources has been developed by the CDC. And there's an algorithm for fall risk assessment and intervention that's shown here. The gist of it is that when it comes to assessing falls, you do the screener, right? Similar to the 3 questions that I posted earlier. You do a functional assessment, like similar to what I described, and time up and go with the tug is what's recommended by the CDC. And inquire history. How many falls has there been? Did this falls lead to injuries? And based on those 3 factors, you can then risk stratify the patient. So if the patient is at low risk because he or she screens negative to the questions or no balance problems were identified on the functional test, these are low risk patients that could be referred to, let's say, a community exercise program to maintain function. If someone's at high risk, meaning that there's been multiple falls, they have balance problems or falls leading to injuries, then you do a multi-component assessment and then redirect them or provide the corresponding interventions as what we have talked about. This is also a patient population that requires follow-up, right, to ensure adherence to the recommendations, to get their buy-in. So motivational, interviewing is part of that process. And again, let's point out that CDC has a lot of resources. You haven't seen this already. I encourage you to take a few minutes, take a look at it. There are clinical resources for providers. There's lots of patient education resources that you can give to your patients. And one of which is the CDC Home Safety Checklist. Right? So this is a checklist that identifies hazards in the homes by the room, right? The environment. And this is helpful for the patient to identify risk factors and then removing those risk factors. So, Sharon, back to you.
So we're going to finish up with talking about how to manage polypharmacy, and I'm going to provide you some tools to help you with this. So really the main way to decrease the number of medications a patient's on is to think about deprescribing. And deprescribing is removing drugs that are no longer indicated. And you want to think about also weigh the risk benefits in determining whether or not a drug is appropriate for removing from a patient's care. You also want to consider, as always, what does the patient want? The patient is on a particular medication. They may want to stay on that drug even though it's not offering any benefit, or they may agree with you that, I'm sick of this drug. So you really want to make sure that your patient values are considered when you are deprescribing. And then you also want to think about life expectancy and time to benefit. I think this is something a lot of people sometimes miss, but how long does it take to achieve the benefit of a particular drug? So for example, statins. You need to be on a statin for 5 years to achieve that benefit. Now look at your patient. Is it a frail 100-year-old patient that is very sickly? Then starting a statin is maybe not a great idea, right? So you want to consider all of these things when you're thinking about deprescribing in an older adult. Now, some ways to, assess your patient's med list, because when you see Like in Geri, we have patients on a ton of medications, and when you look in Epic, it's an overwhelming list. And so you want to be thinking about what are some high-risk medications in older adults. And this list is a compilation from the Institute for Safe Medication Practices. And in acute settings, insulin, anticoagulants, your DOACs, warfarin, these are all high alert medications. Opioids. When we talk about sulfonylureas, hypoglycemics, in the old days it was chlorpropamide, but now it's glyburide. Glipizide is a little bit safer in older adults because it's not renally cleared, but it still can cause hypoglycemia. Benzodiazepines, psychotropics, again, your non-benzodiazepines such as Ambien and the other sedative hypnotics. NSAIDs, digoxin, and anticholinergics. And remember, anticholinergics could be cough medicine, it could be TCA, antidepressants. So you want to be really cautious about those medications. So these are kind of, when you quickly look at a patient's med list, you can be thinking about, these are kind of red flags. Now there's a couple of strategies, and there are more than this, but I selected some strategies to help you think about and guide you in your deprescribing journey. And the first one I'll talk about is a hierarchy that I developed for my learners, for my fellows, for my med students, my pharmacy students. And this is how I approach a patient and when I'm looking at their medication list, or I'm trying to assess whether it's appropriate to approve or order a particular medication. So I start at the bottom of this pyramid. It's set up like Bloom's taxonomy with your most basic knowledge at the bottom, and then it becomes, you become more critical as you go upwards. But when I look at a patient's medication, I first think about, is there an indication for this drug? I think this is the obvious step here. And so I'll use the example again of amlodipine. So let's say I have somebody on amlodipine 10 milligrams daily. And so I look to see if they have hypertension. So if they do, I go on to the next level. Then I'm thinking, is the dose right for this patient's age, their creatinine clearance, right? Let me individualize it to the patient. So I look at amlodipine 10, it's appropriate for this patient. My patient doesn't have any issues. The third step is probably one of the most important steps. This is what I automatically jump to. This becomes second nature, these first two levels, as you're familiar with drugs you often prescribe. But I always ask the question, is there any reason why this patient should not be on this drug? When you ask the negative question, it's a much shorter list because you're automatically thinking about contraindications, side effects, black box warnings, as opposed to asking the positive question, who should be on this drug? I mean, that list is infinite. So if you ask this negative question, you're gonna catch yourself pretty quick in terms of maybe this isn't the best drug for the patient. So if I look at my patient and I say, all right, they're on amlodipine 10, who should not get that? Somebody who's having edema problems, right? So I look at my patient, they don't have pedal edema, okay, so I'm fine. The very top of this pyramid is appropriateness, and this is where you need to look at the evidence. And you look at the patient. Is this the best choice for this patient? So here's where you're looking at your hypertension guidelines. You're looking at the other comorbidities your patient has. So let's say your patient has hypertension, but they also have an ejection fraction of 25%. Well, amlodipine wouldn't be the best choice. Why don't we give them an ACE inhibitor? They need to be on medications that decrease mortality and morbidity for reduced ejection fraction heart failure. So amlodipine wouldn't be the best choice for that patient. So you can catch yourself at that point, at any point in this pyramid. So this is how I think about the medications as I'm reviewing patients' lists. And of course, you want to think about multimorbidities all throughout as you're going through this process. Now, there are other tools that we use in geriatrics and that are quite common. And the first of which is the most famous is Beer's criteria. And Beer's criteria is sort of like our Bible of what are some potentially inappropriate medications in older adults. So this document comes out every few years. The last iteration was in 23, and I think they're working on a new version. But they have nice charts and tables that will tell you why, TCAs are potentially inappropriate. They'll tell you because the high anticholinergic burden, and they'll tell you the strength of that evidence. And then stop-start criteria. This is another document that's used that provides you a list of drugs that are appropriate to stop in patients and to start. And I'll just whip through these. These are some websites. Deprescribing.org is a very popular site. It provides algorithms for different medications you might need help tapering off, like benzodiazepines, like proton pump inhibitors. MedStopper, you can put in whether your patient's frail or not. You put in the medication and it will tell you how high a risk based on the Beer's criteria and the stop-start criteria. And then number needed to treat is a really handy site because it's hard to memorize all of the number needed to treat and number needed to harm for particular medications. So you can put that information in there and it will give you the time to benefit, which is very helpful. And now just wrapping up, we wanted to share with you a pilot deprescribing intervention that we're doing right now with the World Trade Center responders. Many of you have already been approached or have heard about our study, but this is a component of the larger promoting aging, healthy aging study in World Trade Center responders. And we're looking at 50 patients. So we're looking to recruit you all to let us include some of your patients if they fall into our criteria. So we are targeting 5 classes of medications in this particular study. And so what we're trying to do is to facilitate a conversation between the prescriber and the patient about deprescribing. And we do this by providing a patient medication handout about deprescribing to your patients. And so we hope to activate this conversation between the two of you. So we are not making any intervention per se in terms of doing any medical intervention to your patients. We are just trying to facilitate this conversation. So we're not making any changes to the World Trade Center Health Program, but we want to explore the impact of starting this conversation in your encounters. This is the example of the handout that we'll be providing to the patients. And the target medications, this list came from the study that we showed you earlier, the Polypharmacy, that cohort of 7,000 patients. These are the medication classes that were most prevalent in that group. So in summary, we've shown you the interrelationship between frailty, falls, and polypharmacy, that our general responders are aging, and by 2030, we're going to have a large proportion of patients over 65. We've talked about the 5 M's framework, which is a great way for you to think about your patient as you assess the whole person. We've talked about exercise interventions and multifactorial interventions that can help reduce fall risk. And I've talked a little bit about deprescribing and the resources that you can use to help you think about and approach how you determine which medications you might want to consider stopping. With that, we will end and take any questions. Thank you.